All right, a big welcome to all you medical microbiologists out there. In today's explainer, we're taking a deep dive into the modern clinical story of Nocardia asteroides. Now, we've pulled all of this together from a pretty extensive Gemini deep search, and if you want to see all the sources and references for yourself, you can find the link to the full notebook document right down in the description. Okay, let's just get right into it. For decades, Nocardia asteroides was, well, it was a familiar name in the lab, a known entity. But the whole point of our session today is that this bug you thought you knew has been completely redefined. That single species we all learned about, turns out, it's not a single species at all. So what we have now is the Nocardia asteroides complex. And I want to be really clear, this is not just some academic reshuffling to make the taxonomy look neat. No, this is a fundamental shift that has direct, sometimes life or death consequences for patient care. Understanding this complex is now absolutely critical for predicting antibiotic resistance and getting the treatment right from the very beginning. So here's our roadmap for today. We're going to start with the story of this name change. Then we'll walk through what the modern diagnostic workflow actually looks like in the lab. From there, we'll connect that ID to predicting resistance, explore the current treatment strategies, tackle the very tricky issue of AST breakpoints, and then wrap up with prevention and future challenges. You can think of it as a diagnostic detective story, from the bench to the bedside. First up, let's unpack how we even got here. For a long time, viewing Nocardia asteroides as this one single thing caused a ton of confusion, especially when clinicians saw wildly different treatment outcomes for what they thought was the same infection. What's so fascinating here is just watching our understanding evolve. For almost a century, identification was based on a couple of simple biochemical tests. But then you get to 1988, and Wallace and his team notice something that just doesn't fit. They see these different drug pattern types. That was the first real clue, the first crack in the dam, suggesting we were looking at a bunch of different organisms. And then, of course, molecular science, specifically 16S rRNA sequencing, came along and just blew the whole single species concept wide open for good. Okay, so that's the history. Now let's fast forward to today and head to the lab bench. How do we actually approach a sample when we suspect nocardiosis? Well, it all starts with those classic clues that should immediately get nocardia on your radar. These are your initial breadcrumbs. You see those delicate, beaded, branching filaments on the gram stain? And a key thing to remember, it's only partially acid-fast, so you've got to use a modified stain, like a quignon, to really see it well. And of course, there's the slow, chalky, mold-like colonies that can take forever, up to 21 days to show up, often with that unmistakable potting soil smell. These clues are classic for a reason. And this right here, this slide really captures the whole paradigm shift. The old way, waiting weeks for growth, then messing around with biochemicals that were often ambiguous, it was just too slow and not specific enough to really help guide therapy. But the new way, molecular ID, it gives us a definitive species-level answer, and it does it fast enough to directly inform that crucial first round of empiric therapy. So what does that molecular workflow actually look like? Well, it usually starts with 16S rRNA sequencing. That's your workhorse for getting a solid genus and common species ID. For the really tricky cases, or when you need to split hairs between closely related species, that's where multi-locus sequence analysis, or MLSA, comes in as the reference standard. And we're seeing these rapid methods like MALDI-TOF and MNGS become more and more common because they have the potential to give you an answer in hours instead of weeks. It's a real game changer. Okay, and this brings us to what is maybe the most critical connection in this whole story. Why does getting that specific species name matter so much? Because the name itself has become an incredibly powerful tool for predicting the organism's antibiogram. I think this quote just says it all, doesn't it? The work you do in the lab to get that accurate molecular ID, it's not just putting a label on something. It is literally providing the clinician with a probable resistance profile before the formal AST results are even back. And that head start can make all the difference in the world. And here it is, right on this slide. This is the payoff. Just look at Nocardia farsenica. The second you identify it, you can tell the clinical team that it's likely resistant to both trimethoprim sulfamethoxazole and third-generation cephalosporins, two super common empiric choices. Now contrast that with the Nocardia nova complex, which is usually susceptible to a much broader range of drugs. This isn't just data. This is actionable intelligence. So let's see how all this diagnostic info translates into the clinical playbook. Now, one key thing to know right off the bat is that there isn't one single unified international guideline, and that, of course, creates its own set of challenges. If we look at a couple of different approaches, the Dutch guidelines often lean on cotrimoxazole or TMP-SMX as the cornerstone, adding a second drug like amikacin or imipenem for severe disease. But the broader international consensus has really shifted. It now strongly favors starting with empiric combination therapy. That means at least 2 drugs for all severe disseminated or CNS infections. The biggest takeaway here is the move away from starting with just 1 drug, and that's all driven by rising resistance.
And here's why. A massive CDC survey in the US found that a staggering 42% of Nocardia isolates were resistant to trimethoprim sulfamethoxazole, and for some species like Nocardia farcinica, that number can be closer to 90%. So just relying on TMP-SMX alone before you have those susceptibility results back, that is a very, very high-risk gamble. This number alone really tells you why you need that initial combo therapy.
But, choosing the right drugs based on the species name is only half the battle. Figuring out if the bug is actually susceptible in the lab presents another huge hurdle. Which brings us to a topic I know is a major professional pain point for many of you, especially our colleagues in Europe: the lack of standardized criteria for antimicrobial susceptibility testing. The problem is really simple, but it's also really significant. As of right now, EuroCast, the European Committee on Antimicrobial Susceptibility Testing, hasn't published official clinical breakpoints for Nocardia. This creates a real headache for labs trying to standardize their reporting, and it makes it incredibly difficult to compare surveillance data from one country to the next. So what's the practical advice in the meantime? Well, the reference method is still broth microdilution, following the CLSI M24 document. For interpretation, European labs can defer to the CLSI breakpoints. Another perfectly valid approach is to simply report the MIC value and add a comment that official EUCAST criteria aren't available. But what is not recommended right now for clinical use are disk diffusion or gradient strips, simply because they haven't been standardized for this bug. Finally, let's wrap this all up by talking a bit about prevention and looking at the key challenges that are still out there as we close the case file on Nocardia. So prevention here isn't about patient isolation rooms, because person-to-person spread just isn't a thing. It's all about managing the environment and protecting vulnerable patients. Nocardia is everywhere, in soil, in decaying plants. So for your immunocompromised patients, especially transplant recipients, prevention means simple, practical education. Wear high-quality masks and gloves if you're gardening or doing yard work. And in the hospital, it means being super vigilant about dust control during any kind of construction to protect those at-risk patients from breathing it in. And this really brings us to our final thought, which kind of circles back to everything we've talked about. We've seen how molecular diagnostics have totally changed the game, but huge hurdles are still there. Resistance is evolving, treatment ideas vary, and as we just saw, testing standards are not harmonized across the globe. So the central question for our entire field is, how do we build a truly global, standardized approach to fight this really complex and challenging pathogen? And that's all for this deep dive into the Nocardia asteroides complex. I really hope you found it valuable. Please subscribe for more explainers like this, and I'd love to hear your thoughts and questions, so drop those in the comments below. And don't forget to check out that notebook for all the source material. Thanks so much for watching.